Well, welcome to another episode of MD Insight. I'm delighted to be here today with Dr. Florian Rieder. Florian is one of our gastroenterologists in the Department of Gastroenterology, Hepatology and Nutrition at Cleveland Clinic, and his particular interest is inflammatory bowel disease. So Florian, welcome, and thank you for being here with me. I thought it might be fun to start off by saying how you ended up being in Cleveland, let alone the US. Like me, you're a non-national originally, so I thought people might be interested in hearing a little bit about your pathway.
We are non-national and everyone can hear it. So I have quite an unusual way to the United States. So I trained in Germany, did an MD PhD there, and ended up in the United States for a finite period of time, initially 2 years with a government grant. But met my wife a month after I arrived. My wife is a surgeon at the Cleveland Clinic, endocrine surgeon, which ended up me staying. I repeated all my training here. So I trained before in Germany, internship, residency, fellowship, and now I have my own operations.
There you go.
It's interesting how life can change,
isn't it? Yeah, I mean, I came here for a year, and that was 20 years ago. My crystal ball isn't very good. So, and then you evolved into IBD. So tell me a little bit about why you picked, GI maybe, but certainly IBD within GI. What drew you to that?
So I have, during my PhD thesis in Germany when I was a medical student, I worked with a gastroenterologist who had a busy IBD practice, but had a lab studying novel therapies in IBD. And back then, even more than now, it became very apparent that therapies are insufficient for patients with IBD. And there's a big need to develop novel approaches to treat these chronic diseases. And I like the combination of lab and procedural ability brain, because it's a very wide field. So I ended up in GI, specializing on inflammatory bowel disease. I think there's a huge need to improve quality of life of patients.
Yeah, I think that's true. There's certainly a huge need to improve quality of life, but I think also it's a field that there's been a huge amount of scientific investigation, but most of it's been on the inflammatory side. So you've come up with a different area. Maybe you tell the audience a little bit about why and then what the potential is, because I think that's when it really gets exciting.
So what we're excited about is a complication of Crohn's disease, fibrostenosis in Crohn's disease. More than half of patients with Crohn's disease develop it over their lifetime and becomes clinically apparent with obstruction. Need for surgery is very high. And all we do is mechanical therapies, which is either balloon dilation or surgical intervention. And there is no specific therapy for that. The anti-inflammatory therapies cannot prevent or treat fibrostenosis in Crohn's disease. So it's a large area of need, and we started about a decade ago to think about how to approach that. And have built in the meantime a true bench to bedside approach, from patient observation back to the bench and vice versa. Developing novel targets, we have a large discovery group. And now recently we have an international group that we formed to develop clinical trial endpoints, because while we understand a lot about the disease and a lot about why strictures form in the lab, no company has yet triggered a clinical trial because they feel the endpoints are not established. And this is a huge operation to establish novel regulator-accepted endpoints. So we formed a consortium with the Mayo Clinic and the Clinical Research Organization to develop just that, and then hopefully in a few years trigger the first clinical trials in a subgroup of Crohn's disease patients with fibrostenosis.
Right, and so the endpoints, that's around imaging, particularly?
So imaging
so
will be, I think,
I'm
very
sure
important.
people would be interested. Maybe talk a little bit about what kind of endpoints you're thinking of, and what should we be achieving?
So the FDA for IBD trials generally requires 2 endpoints. One is patient-reported, because the patient needs to feel better on a specific therapy. And this needs to be standardized. It's called a patient-reported outcome tool development. It's one arm, and then we are developing 2 additional arms: imaging as an objective marker that is required for approval of a drug. And we go for MRI and CT and enterography, defining strictures, what constitutes improvement, and so on. And then the histopathology side should not be forgotten. So can we histopathologically standardize what a stricture is? And we hope that this combination, together with working with regulators early on while we develop these tools, then helps them accept that. And there are a lot of antifibrotics already available from the liver, lung fibrosis, skin fibrosis, heart fibrosis. They can easily be adopted. And this is the goal of this operation. So we will have these instruments ready early next year. and we're already in contact with about 24 industry partners, and then hopefully they feel confident enough to move forward.
And so that gives us a clinical endpoint that we can measure and we can look at. Maybe tell us a little bit about some of the basic science work that you've done, whether it's lab or models to see, because with fibrosis, one of the challenges I think is how do we reverse it, right? It's present inflammation, we can dial it down or cool it down and make a lumen wider. But with fibrosis, how do we reverse it? Can we reverse it? What are your thoughts about that?
Yeah, so I have the dream that fibrosis is reversible, but I think it is a very tough task. And the way we study it in the lab is the backbone is primary human cell culture. So when you resect the tissue, we get it in the lab and we can isolate all the cell types responsible for fibrosis from the human tissue, from disease and health, and can look at differences. We have large screening programs, omics approaches with proteomics, transcriptomics, single-cell transcriptomics to find novel targets, and then we do what is called validate those. So we have primary human cell models, we have a variety of animal models, and if this drug is successful in all of those, then you can propose to, for instance, an industry partner to invest the money into a larger trial, which is something the clinic can support, but we don't obviously have the infrastructure to do it. So I think these partnerships are critical.
Yeah, I agree. I think if we can, obviously you've got to come up with the innovation, which you're doing, and then prove it, but it's through partnerships and collaboration with others that we'll be able to do the trials to show it works. So, well, look, thank you very much. That's a great insight into some of the exciting future of how we might be able to treat patients with IBD, because it's a challenge. And if they end up seeing me for surgery, it's obviously less than ideal. Right?
It speaks for you. Wishing me luck, because if we're successful, we'll be out of work.
Fortunately, there's lots of other things we operate on. No, it's a good thing. It's at the end of the day, it's all about how we make it better for patients and how we improve it, because it's a tough condition to treat, as you well know.
I agree, but collaboration is critical. So, which is something very unique at the clinic. No barriers between colorectal surgery, GI, pathology, radiology, and this is how I think these projects really happen. So, congratulations to you for creating this environment.
No, I think it's all of us. We're lucky to work in a place that's culturally very special. So, and congrats on all you're doing. And thanks for being here with me today.
Thank you.
Appreciate it.
Thank you for having me.